that would be frightening. All right, so last time we talked about action potentials. They're generated in the neuron and travel down the neuron. And that doesn't necessarily allow cells to communicate with each other. Well, it doesn't. It triggers what we're going to talk about now. It triggers the release, typically, of some chemical transmitter to communicate with the next cell down the line. The action potential itself doesn't cause depolarization. It's not an electrical change that is transferred to the next neuron. It's via some kind of release of some kind of chemical messenger, typically. Not all the time, but most of the time. So that's what we're talking about today. This synapses and synaptic transmission between neurons, but this also happens between muscle cells and also between glands. Okay, so there's some synaptic transmission that occurs there. So a synapse is just a specialized point of contact between a neuron and another neuron, muscle cell, or gland. Information is transmitted from one neuron, the presynaptic neuron, to another cell or neuron. The postsynaptic neuron or postsynaptic cell is what's going to receive that information. Two types of synapses. There's an electrical synapse, which is much less common to see that. And these are through these specialized connections called gap junctions, which are really small, little tiny areas that are much smaller than even a typical synaptic cleft or synaptic junction. These are smaller even, and they're really close. They're only 3 nanometers apart. That's 2 cell membranes between the cells. And there's actually these proteins, embedded protein channels that connect the cell membranes from one cell to the next directly in these kind of open pores. They're called connexins, and allow that direct communication. It actually allows direct movement of charges from one cell to the other. So it does allow propagation of these action potentials directly between cells. But that's very unique, and that's mostly like in cardiac muscles, so that you get that, you create that, initial impulse at the SA node, and then that goes through and spreads through the heart cells through the direct connection of heart cells through these connexins and the passive spread of that action potential throughout the heart. So we do have cardiac. Some smooth muscle also contracts this way, has these connections, and some glands, and there's glial. Remember I said glial cells? Now they're thinking they do play some role in communication within the nervous system and modulating nervous system activity within certain regions because of this ability to have some charge passively spread between them and these glial cells. So this is just showing you a picture of this little tiny gap junction there where you've got this approximation of the cell membranes and these connections, the protein channels that allow ions and the charge to pass directly through to the other cell. The one we're going to spend the rest of our time on is chemical synapses, the most common type of synapse, and the one that allows transmission of information longer distances and those kind of things. So you have a presynaptic terminal, also called the axon terminal or the terminal bouton. So all 3 of those things are synonymous. So presynaptic terminal, axon terminal, terminal bouton. Then you have the cleft or the gap between, okay? And then you have the postsynaptic terminal, which is the membrane of the target neuron, the membrane terminal or postsynaptic terminal. And you typically have some type of neurotransmitter or modulator. This is the chemical that contains in small vesicles for allows the communication between the neurons. You can have, these synapses can be classified in a couple different ways. It can be called axosomatic, where an axon of one neuron is connecting with the soma directly, the cell body. Axodendritic, where you actually have an axon communicating directly with the dendrite. Or axoaxonic, where you can actually have axons communicating with other axons. Okay, and we'll show you a picture of that on the next slide. Or, no, at some point we will show you those. So here's the presynaptic axon or terminal bouton that you see, and then the synaptic cleft, and you see some neurotransmitter going into the synaptic cleft, and then you have the postsynaptic membrane with receptors, and these receptors are specific typically to a certain type of neurotransmitter. Okay. this is showing you those different connections here. So, you know, here is that axosomatic connection. So you can have axon connecting or communicating with a region of the actual cell body, which can have receptors on it, receptors that are specific to those neurotransmitters. Here's an axodendritic, so you can actually influence, this is the dendrite here. So, and then you can have actually axo-axonic. So here's one axon influencing the activity of another axon. And then we'll talk about presynaptic facilitation inhibition as another way to regulate activity of the nervous system via these axo-axonic synapses that can then, this axon can influence what happens with this axon and how much neurotransmitter it releases. It can either ramp it up or turn it down. It's just another way of influencing overall excitability of the nervous system, toggling it or ratcheting it up or down. So the summary of events that happen at a chemical synapse is the action potential reaches the presynaptic terminal, and that's, that saltatory conduction, if it's a nicely myelinated neuron, and that voltage-gated sodium channels opening along down the line and allowing that directional movement of ionic charge down the axon until it reaches that presynaptic terminal. When it reaches that presynaptic terminal, that change in voltage, when it gets to the presynaptic terminal, opens voltage-gated calcium channels. Okay, so voltage-gated calcium channels are down in the presynaptic terminal. Remember we had a lot of voltage-gated sodium channels up in that axon hillock, that initial segment region that initiated the action potential, and we also have them down the nerve too in those nodes of Ranvier. But then down in the presynaptic terminal, we have a lot of voltage-gated calcium channels. So then they respond to that change in voltage. And then so they open, calcium comes in, and calcium through some chemical exchange there helps cause the vesicles, the little vesicles that are stored down there that have neurotransmitter, to move to the cell membrane, bind with the cell membrane so that then they can be released through the process of exocytosis. Okay? And then the postsynaptic membrane, so neurotransmitter then is released into the synaptic cleft and binds with the postsynaptic membrane receptor that is typically specific to that neurotransmitter. And then the postsynaptic membrane channels change shape, allowing ions to either enter the postsynaptic cell or activates intercellular messages through this kind of G protein mediated pathways. It's either can do a fast acting or slow acting depending on the types of neurotransmitters and the types of receptors we're talking about. Okay? And then the neurotransmitter, all of them don't end up binding, so some are left over. And so it's either diffuses out of the way, and some of the glial cells will take some of that away, because if you don't want that signal to last for too long, you only want it to last for a certain amount of time, and you don't want too much neurotransmitter sitting there. So either some of it will just float away and the glial cells will suck it up, or some that remains in that will be reuptaked, okay, and through endocytosis and recycled, okay, and repackaged. So that's how you get stuff out of that synaptic cleft that's left over that wasn't bound initially to the receptor sites. Because once the receptor sites only hold on to the neurotransmitter for so long, and then they go away, and then at that point you want it to be done most of the time. And so then you don't want more neurotransmitter sitting in the cleft to bind again to the receptor. So this is just showing you this process. Here's the charge coming down the line here, down the axon. You see the flip-flop of charges, gets more positive on the inside, negative, that flip-flop there. And then once it gets down to the presynaptic terminal, that causes voltage-gated calcium channels to open and come into that presynaptic terminal. That triggers the vesicles to move to the cell membrane and bind with the cell membrane, and then be released through exocytosis into the synaptic cleft. There's our neurotransmitter. And then those bind with these receptor sites on our channel proteins there, these would be ligand-gated proteins, right? So these are ligand-gated proteins. So the voltage-gated, and then that then can cause a change. It can cause anything. It can cause It can cause an excitatory postsynaptic potential. It can cause an inhibitory postsynaptic potential if it falls on chloride channel ions and lets more negative charges in, or if it falls on sodium channel ions. It depends. There's all specific though, that neurotransmitter and the receptor site. So, or it can activate G protein mediated pathways that are more longer acting modulation of neurons. Then whatever that does, in this case, it's opening up some ligand-gated sodium channels, and positive charges start moving in, creating, this would be an excitatory postsynaptic potential, and if it reaches threshold, it may cause another action potential in that next neuron. Okay? So then we talk about these electrical potentials at synapses, these local potentials, which we mentioned last time, that can either be excitatory. That's how we talked about it last time. We purely talked about the excitatory nature of these local potentials, because we're going to try to get to threshold, generate an action potential. But you can also have inhibitory postsynaptic potentials. Just like you can turn something up, there's always a way to turn it down. Okay? So you can excite the nervous system and the next neuron through the excitatory process, and excitatory postsynaptic potentials, or you can inhibit the next neuron through inhibitory postsynaptic potentials. So an excitatory, or EPSP, causes some depolarization where the inside gets less negative or more positive relative to the outside. If you get enough summation to get threshold, you're going to get an action potential. On the flip side of that, if you have an inhibitory postsynaptic potential, you're going to get some hyperpolarization. The inside's actually going to get a little more negative, okay, compared to the outside. Typically there's two ways of doing that. You can either open up some chloride channels. And chloride, there's actually a chloride pump in your cell membrane. So there's a higher concentration of chloride outside your cell. So there's a concentration gradient, pretty strong concentration gradient, actually quite strong concentration gradient for chloride, because the inside of your cell is more negative already. And so chloride has to move against an electrical gradient, and it has to have a strong enough concentration gradient to move against its electrical gradient to come into the cell. But it is strong enough that it does. So when you open up some chloride channels, they migrate in, make the inside of your cell even a little more negative. So you go from minus 65 millivolts maybe down to minus 70. And now you hyperpolarize that cell. So anything excitatory comes down the line, it's going to be a little harder to stimulate that neuron. The other thing you can do is you can actually, so remember we have the potassium that's being pumped into the cell, right, by the sodium-potassium pump, and it's leaking out through leak channels a lot. You still have a negative, you're more negative on the inside compared to the outside because you're pumping out the 3 sodium ions on the outside. It's constantly going. But if you want to make your cell slightly more negative for a brief period of time, you can open up some potassium channels and even let a little more leak out even faster. And that's leaking out more positive charges, right? So even more potassium's leaking out, and you can get your cell to get a little more negative. So again, going from minus 65 to minus 70 or whatever millivolts. So those are the two main ways. Let a little chloride, let a little negative ions in and make it more negative on the inside, or let a little more positive potassiums out to make it more negative on the inside. And that's all due to the concentration gradients that you have and electrical gradients and how those work. So this is just showing that. Here's an excitatory postsynaptic potential where you get neurotransmitter falling on a ligand-gated sodium channel, opens up, you get some positive charges moving in, you see a little excitatory blip, a local potential that causes some depolarization. Then this is a ligand-gated chloride channel. Chloride is much more concentrated on the outside of the cell, so it wants to move in even though the inside is more, even though it's negative here, you typically wouldn't expect negative ions to move into negative territory, but there's a strong enough concentration gradient that they still move that way, at least some of them, okay? And so, but that's enough to then get a little bit of a dip where now, because you've moved a little more negative charges in here, it gets a little more negative on the inside of the cell. And it's a temporary dip because the chloride pump is going to pump it back out eventually, but you can get these little modulatory impulses that regulate the immediate excitability of the nervous system at any given moment. Okay. Now we'll talk about the concept of presynaptic facilitation inhibition, another way to kind of regulate the nervous system. It's when the amount of neurotransmitter that is released is either increased or decreased and is influenced by the previous activity of an axo-axonic synapse. Okay? So presynaptic facilitation is when via an axonic synapse, as this action potential is coming down, if this presynaptic connection here, if this neuron presynaptically, before this synapse, caused some sodium to already be entered into that presynaptic terminal before the action potential even arrives, it enhances the strength or the strength of that response, of that action potential, so you're likely then to even get rid of more neurotransmitter, okay, or release more neurotransmitter because you've like primed it. You've primed it by already throwing a few positive charges in before the action potential even gets there. So when the action potential does arrive, you're actually going to release a little more neurotransmitter than if you didn't have that primed kind of influence. And so some of this presynaptic facilitation and inhibition, you know, influences things like pain modulation and chronic pain responses and things like that. So, you know, like for example, persons with chronic pain, some of the neuroplastic changes that occur in response to having chronic pain can be too much presynaptic facilitation. You get a little too much enhancement of that effect, so any signal that comes through that pain pathway gets you know, magnified, so it feels more painful than it should normally be because they've got this presynaptic facilitation. So by doing exercise or manual therapy, by giving physical input into the nervous system that's maybe non-painful or different, you might be able to downregulate that or increase presynaptic inhibition to counterbalance some of that stuff. And that's what you get through doing repetitive tasks and input to the nervous system. And it's just a matter of finding the right input to the nervous system. Most of the things we do, we're trying to modulate the nervous system and the neuromotor system up or down in response. We're trying to get the right output with the input we provide into the body, or the physical activities or experiences we make the person and their nervous system experience. So, but this is just one way that is modulated. So that's presynaptic facilitation. Then presynaptic inhibition is just the opposite, where you have an action potential coming down. Here's your presynaptic connection at this axonic synapse. This, in this case, might either open a few chloride channels, so you get a few negative charges going in there before the action potential gets there, or it might open a few potassium channels, so you're already leaking a little too much potassium out. Makes that end of the neurotransmitters a little more negative than previously, so when that action potential gets there, it's not going to be as effective at releasing neurotransmitter. The response is not going to be as strong. You'll still release some, but you're not going to have a strong of a response. And that's presynaptic inhibition. Any questions on that stuff? Yeah. Yes. So it's when you define presynaptic inhibition or excitation, it's always an axonic. It's one axon influencing the other axon. And it's typically right down there at the end, but I don't know if it could be higher up on the axon. Usually there's myelin protecting the rest of that, so it's hard to influence the axon where there's myelin in the way. So you really have to influence it at the terminal bouton, the end, that presynaptic terminal, where you can influence it and have enough exposed receptors that'll bind that. So, okay. Now we're going to talk specifically about the synaptic receptors, okay, that are binding the neurotransmitter. The vast majority of them are ligand-gated ion channels. Okay, that's what the synaptic receptors are typically, are a ligand-gated ion channel that function like a gate. The gate opens upon binding the neurotransmitter. It's pretty fast acting, binds for a millisecond or two, and then it releases. Okay, and then once it releases, it inactivates. There may be a little delay, maybe another few millisecond delay when it finally closes. So different gates have different delay timing on them, and we know the action potential, that's important, so you can keep them open, you'll let enough through, but then delay the other opening of the other ones until you've got enough through, and then you open the potassiums to let them out, but everything has to be timed. So there's some timing to them, but generally it's pretty fast acting, We're talking just several, hundreds of milliseconds or less, and that's how majority of synaptic activity is mediated by these ligand-gated channels. There it is. This is your neurotransmitter binding, and that's the ligand, is the neurotransmitter. We have what are called, another type of receptor is called G protein mediated receptors, and they are also can be ligand gated, but they're not ligand gated, I should say. These aren't typically, G protein mediated receptors don't really act by functioning on opening or closing the protein channel that they bind to itself. Now the G protein activated by this may go and open up protein channels that are nearby, but they don't. The G protein mediated receptors don't typically just open and close based on a ligand binding to it. They activate a G protein attached to the receptor, so really not a gated channel, I should say. So G protein mediated receptors, they're more complex than the ligand. Pure ligand gated channels just open and close in immediate response to that ligand binding. These bind the ligand, which activates the G protein, and the G protein can do a number of things, which we'll talk about. Okay. They're slower acting, like they last for seconds, minutes, days, hours, months. Some of the changes that occur via like long-term changes to synaptic activity, through chronic pain, through motor learning, all that kind of stuff, some of these G protein mediated pathways can last for months and years, and then take a lot of effort to change if you want them to change through training, repetition, those kind of things. Or some of like your descending pain modulatory systems, some of those are G protein. You have your fast pain, you have your slow pain. Fast pain responses like the immediate, "Ow, that hurts," and then you get that initial hurt and pull your hand away. Those are typically through more of fast-acting ligand-gated channels and connections between neurons. But then that dull ache afterwards, that kind of pounding dull ache, that means don't get anything near this or use this thumb again after you whacked it with the hammer for a while. Those are G protein mediated receptor connections that keep the pain lasting even longer periods of time to keep you from hurting your thumb again if it's really truly injured or something like that. So here's what we are talking about. So here is a neurotransmitter. It is a ligand, but it's not binding to a ligand-gated channel. So you notice there's no opening in this receptor, right? It's not like just a channel or a gate that opens. The neurotransmitter binds to this G protein mediated receptor. So this is a receptor that has this little complex, an alpha, beta, and gamma subunits. Typically this G protein has 3 subunits to it that are connected to that receptor. When that connection happens, it activates, which in this case the activation is just converting GDP to GDP to GTP. Okay, that's not that critical. You don't need to understand the chemical nature of this, just the more conceptually. This conversion, what it does is it just, in this case, this is just demonstrating one example. This is not how all G protein things work, but here's where a G protein is activated. In this case, this alpha subunit, because of this conversion from GDP to GTP, causes it to be cleaved off, and it floats to a nearby G protein mediated receptor that activates and opens its gate. So there's an extra step that is occurring here where it's causing, and this takes some time, so this takes might take a few seconds for this thing to find its way over to, and it may stay bound to this receptor for several seconds, several minutes, several hours, and cause that protein channel to stay open a lot longer than the typical fast-acting ligand-gated channel. Does that make sense? So this is where the G protein itself is actually causing the protein channel to open or close. So this is where the G protein is mediating this response. That's one way G proteins can influence synaptic activity. Okay? Then the other way is through what's called the G protein mediated second messenger system. Okay. So this is where that little G protein, or part of that G protein, goes over and activates an intercellular target protein. Then that intercellular target protein does something and initiates the next response. So there's a second messenger in this. The first messenger is the G protein. The second messenger is whatever, and typically the G protein is going to go and activate an enzyme within your cell. That enzyme is going to create something. It's going to create another messenger, or another molecule. Then that molecule is going to go do its job. So it's another extra step in the process, and that's the second messenger system. So the G protein is the first messenger. It's the whatever that enzyme it activates produces as the second messenger. Okay. And these little second messenger molecules, whatever they might be, can initiate one of the following. They can, just like the G protein we saw in the last slide, can go and open up a gated, ion channel. That second messenger molecule can do the same thing, and it's going to, again, maybe bind longer. It's going to take a little longer to. It's going to open that longer, or whatever. Or it can go into the nucleus, and it can activate genes and cause synthesis of cellular products. So let's say you have a cell, and maybe you're learning a new skill or activity, and you're activating these neurons over and over again, and you want these neurons to get better at communicating with each other. So you're saying, hey, I'm using these neurons, and they're connecting a lot. They're not quite as effective as I'd like them to be. I'd actually like to add some more protein channels on my cell membrane to actually allow more efficient communication between these neurons. And so through the G protein mediated pathway, if you keep stimulating that, it will send a second messenger into the nucleus to say, hey, send out some messenger RNA to go out and be transcribed by the free ribosomes to create more protein channels on my cell membrane. That might take weeks, months to get that process to occur, through some process. And we can do the opposite. We can tell it to take away and cleave off and get rid of some of those if we don't want that connection to happen. Again, that just takes time, and so that's one way the second messenger system can work. The other thing they can do is these second messengers can modulate overall calcium concentrations in the cell. Calcium, when you have more calcium in your cell, it increases overall cell metabolism. Less calcium downregulates that. Okay. We also know calcium is important for other things like muscle cell contraction and heart muscle contraction and so forth. But calcium within cells and within neurons just generally raises or lowers the metabolic rate to do things like create more cell membrane proteins, or reduce them, or so they're like stoking the fire. If you add more calcium, you can increase the cell engine to do things and make it more active, or you take calcium out and the metabolism of the cell goes down, or the neuron goes down. So it just generally regulates metabolism of the cell as a whole. So those are some of the main ways the second messenger system can act on influencing your neurons. So here's another example here, just breaking it down. So, the picture I showed you from your Lundy-Ekman book shows this G protein like actually kind of right here next to it and connected to that. It doesn't always work that way. It's just they're embedded. All these are embedded or attached to the cell membrane, and they're just close to each other. Whether they're right next to others or actually part of it, but they're close to each other. And so here's a neurotransmitter binding to a G protein mediated receptor. It's right next to the G protein. The G protein is activated in some way. It may break off a part of its alpha, beta, gamma chain or something like that. Then that may float over here and tell an enzyme to now start making another molecule that becomes the second messenger. Then that second messenger can go activate protein channels directly, or it can go into the nucleus to tell, hey, nucleus, make more cell products, make more receptors on my cell membrane, take some away. Or it may go and just bring in more calcium to make the metabolic process of your cell go up, or it may tell calcium channels and get rid of more calcium, so you bring the cell activity down in general. So those are some ways the second messenger system can work. And this is a nice just overview kind of table that shows you some of that. So this is the receptors that land. This is the ligand-gated ion channels. You get that brief opening of a channel, you know, and you get local depolarization or local EPSPs or IPSPs, okay, related to that fast-acting ligand-gated channel mechanism. So that's the one thing we've talked about. Then here's the G protein pathways, mediated receptors, which can do one of three things. That alpha chain we talked about by itself, that direct piece of that G protein can go float over and cause more prolonged opening of ion channels that span the membrane. And that also can cause local depolarization or hypopolarization of the membrane. It can make it up or go down, you know, depending on the type of membrane receptor it opened. Did it open a chloride channel? Did it open a sodium channel? Did it open a potassium channel? You know, depends. That second messenger can go into the cell nucleus and activate genes. So then the other one is a second messenger system. So that G protein piece floats over, tells an enzyme to produce a second messenger. That second messenger can activate genes in your nucleus that then can increase the rate of synthesis of specific cellular products, which could be protein receptors, or it could increase the number of neurotransmitter vesicles you put down your presynaptic terminals, so you release more, or it could downregulate that, so you release less neurotransmitters. So that's how you can regulate overall function. And then also we talked about how those the second messenger system can just modulate overall calcium levels within inside the cell, which just affects cell metabolism and other processes. Ramps it up or ramps them down. Okay. So the combination of all these are all happening all at the same time. All this happening at the same time influences whatever resting state of your nervous system is, and then how it responds to both input and how you respond through your motor output and so forth. So just that's how we regulate nervous system activity. That makes me think of dentists when I just heard that, which I haven't been a dentist in like 5 years, and I'm like knowing I'm going to be hearing that when I go in there, so that's why I haven't been. I keep putting it off. So, you know, last couple weeks ago, my tooth really started hurting, and I'm like, I got to make that dentist appointment. And I was about ready to call, and then it stopped hurting. I'm like, well, I don't need to go to the dentist now. It stopped hurting. So I'm not good at the whole wellness preventative stuff. All right, second messenger systems. Here's some examples of second messenger. You don't have to, it's not that important to memorize these. These are just examples of how the second messenger system, a couple examples of how second messenger system is influencing different processes in your body. So one is this cyclic adenosine monophosphate, or cyclic AMP process. So the cyclic AMP system, so here's an example of how this system helps regulate the sympathetic control of your heart and how your heart rate goes up via sympathetic input into your heart. Okay, so this would be for the sympathetic increase in heart rate and heart rate contraction. So norepinephrine binds to one of your cells, your cardiac cells, and activates a receptor, a G protein mediated receptor. That G protein then floats over and tells adenyl cyclase, which is an enzyme in your cell, to start making cyclic AMP. Cyclic AMP is therefore your second messenger. So the adenyl cyclase is an enzyme that creates the second messenger, which is cyclic AMP. Cyclic AMP then goes over and causes phosphorylation and opening of calcium channels in your cardiac cells. And so when calcium comes in, that makes your heart rate go up and makes your cardiac cells contract and makes that contraction stronger. And you notice when this happens, like you get on a treadmill, you do something, there's a little delay before your heart rate it doesn't immediately go up. You start running, there's a little bit of a delay. It takes a little bit of time for this cyclic AMP system to kick in. And then when you stop, running, it doesn't just immediately, your heart rate doesn't drop to zero, or not, hopefully not to zero, but back to resting immediately. It takes a little bit of time to ramp back down, and that's because then this lasts for a little while. There's a little after effect when you stop activating it, because it's just, turns on and stays, and it knows you're going to maybe be physically active for a little bit, so it takes a couple minutes, for this to kind of process to occur. So this is the cyclic AMP system. This is the case of heart rate, increasing heart rate. But there's also, the cyclic AMP system is also very important in some pain transmission, is modulated this way. Morphine specifically activates G proteins that inhibit adenylyl cyclase, that actually downregulate that, so you create less cyclic AMP, which when you have cyclic AMP in certain pain pathways causes increase in pain responses. And so morphine activates a G protein that inhibits cyclic AMP. In this case, with norepinephrine, it actually has a G protein that causes cyclic AMP production to go up. It increases adenylyl cyclase activity. So, and then the arachidonic acid pathway is also another G protein pathway. So here, in this case, this would be like an allergic response can happen here. So histamine could bind to a receptor, a G protein mediated receptor here, and that causes, the G protein activates phospholipase A2, which is a type of enzyme, okay? That causes, so phospholipase A2, when it's activated, will produce arachidonic acid. That second messenger will then actually cause your cell to produce prostaglandins, which causes vasodilation in the area of inflammation, okay? And so this would be a second messenger system in the inflammatory pathway, okay? So it's a G protein mediated process or pathway in the inflammatory process. So it's not, these G protein mediated things don't just work with neurons, they work with other cells. Like this would be, cells of your vascular system and the tissue right around, like where you've had an injury and or having an allergic response, the tissues within your nasal cavity and so forth. You can have these G protein mediated pathways that not only work in neurons, but they can affect other cells too. Arachidonic acid is this process leads to prostaglandins, which can regulate vasodilation and inflammation, but also increases they make you more sensitive to pain too. When you have prostaglandins around near your free nerve endings, you perceive pain, they heighten your pain response. And so things like aspirin and other non-steroidal anti-inflammatories, they inhibit the enzyme, the phospholipase A2, in the G protein mediated cascade. So when you get to NSAIDs in your pharmacology, you'll understand that you're inhibiting this G protein mediated pathway by inhibiting phospholipase A2. So you can't produce arachidonic acid, which then makes your inflammation seem less and your pain is less because your free nerve endings are not as hypersensitive because of there's not the prostaglandins around. So, any questions on that? Let's just take a short break here, come back in 7 to 10, and then we'll be able to still, I think, wrap it up a little early. I'm going to talk about specific neurotransmitters and their specific receptors. We've been talking about ligands and neurotransmitters in general, receptors more in general, like just are they ligand gated, fast acting, are they more G protein mediated. Now we're going to actually get into specific types of neurotransmitters and their specific subsets of receptors a little bit. All right. Come on. So, neurotransmitters / neuromodulators, okay? Most of these neurotransmitters or modulators are classified as amino acids or their derivatives, which are amines and peptides. One exception is the cholinergic transmitter acetylcholine. Okay, so that's one exception to that general rule. Neuromodulators, while they really fit into a broad category of a neurotransmitter. Okay, they tend to be longer acting and or cause changes in larger networks of neurons, and they utilize G protein mediated pathways. So if you utilize a G protein mediated pathway, you're typically considered more of a neuromodulator. Okay? If you're just doing fast acting, opening ion channels briefly, then you're a true neurotransmitter, you know. But there's still I mean, these are all fitting under a broad category of some type of neurotransmitter, but we're like fast acting neurotransmitters versus slower acting neurotransmitters / neuromodulators. But I'll try to make sure I don't ask a question that would screw you up because of that kind of nomenclature. So common neurotransmitters and neuromodulators. These are the ones, the bread and butter. There's lots of others. We're just going to focus on these right now. So neurotransmitters that are typically fast-acting most of the time, there's typically always some exception to some of these rules, are going to be acetylcholine, which it tends to be fast-acting in the peripheral nervous system. However, acetylcholine is also used in the central nervous system where it activates G protein mediated pathways, so slower act. That's where it's kind of the mostly. So acetylcholine is fast acting if you consider it just what its activity does in the peripheral nervous system. GABA, glycine, and glutamate. Okay, so don't ask me why it took me 20 years to figure this out, and you guys already probably see it. If it's got a G, if it starts with a G, it's fast acting, and if it's a neurotransmitter fast acting. If it starts with an A, it depends, depending on its peripheral central nervous system. All the rest are, if it doesn't start with an A or a G, it's going to be a neuromodulator, right? Does that make sense? Right? The rule works. Dopamine, serotonin, substance P, endorphins. So, man, that would have made my life so much easier all these years. So, glad we could figure that out together. So the neuromodulators, which are slower acting, again, most of the time, except for acetylcholine in the peripheral nervous system, are generally activating G protein mediated pathways. And these are dopamine, serotonin, norepinephrine, substance P, endorphins, and acetylcholine. And they also tend to affect larger networks of neurons. When you're just discretely activating one neuron with another, that's when you use the neurotransmitters fast acting. When you're wanting to make a big whole group of neurons, they either upregulate or downregulate their activity, you're usually squirting neurotransmitters into a whole region of the nervous system to affect the general activity of a whole region of the nervous system. Okay? So don't have to memorize these pictures, but I want you to see how these neuromodulators, so these are all neuromodulators. There are certain regions within our nervous system, typically referred to as some type of a nuclei, which is a group of cell bodies, and a fair number of these are actually in the brainstem, okay? But so serotonin is a neuromodulator, and we'll get into what serotonin does later here, but there's a couple places in your brainstem, couple nuclei. These are the raphe nuclei in your brainstem. They're sitting in what's called the tegmentum of your brainstem. Remember that middle section, that meaty section there's lots of stuff in there, including these little groups of nuclei, which is just cell bodies, and there happen to be these raphe nuclei. Some of these raphe nuclei, their axons project up and then distribute throughout the entire CNS, okay? If they're projecting up into the cerebrum, they're squirting their serotonin into those various cerebral areas to maintain a certain basal rate or level of activity of neurons that are moderated by the serotonin level, which are activating G protein modulatory pathways that make those whatever neurons more likely or less likely to activate and help regulate things like, you know, your mood and those kind of things, and general feelings versus discrete feelings or discrete movements. They're regulating just how you feel at a given moment and those kind of things. We do have some raphe nuclei down lower in the brainstem in this pontomedullary junction that send axons down the spinal cord and squirt some serotonin in your dorsal horns so that when pain signals come in, if you squirt a little serotonin in the dorsal horn, as pain signals come in, you can down-regulate. The pain doesn't seem so bad. It's a descending inhibitory modulatory control mechanism. So, you know, after you've banged that thumb, you got the immediate pain response, Then you start getting the throbbing of the thumb and the aching, which is mediated by sensory pathways that are G protein mediated. But then you have the raphe nuclei will go, uh-oh, we're having some long-term pain and aching here. Let's down-regulate that a little bit. Let's start getting that under control. Let's go squirt a little serotonin on the dorsal horn so that those signals that are still coming in we don't perceive it as so bad, you know. So, but that takes minutes to happen and sometimes hours to happen for that process to occur. Then we have norepinephrine, which is also in several different areas within your brainstem, is where most of the nuclei that have axons that, again, project to wide, big areas of your nervous system and squirt norepinephrine into various regions. Norepinephrine, I'll wait till talk. We'll go through each of these and talk about their main functions. Acetylcholine here. Acetylcholine it gets squirted into more specific regions of your central nervous system, specifically the basal ganglia and this prefrontal cortex via the medial forebrain bundle, which you don't really have to know, but this medial forebrain bundle is just the axons that are taking up that are coming from these cell bodies, you know, located in the pedunculopontine nucleus, that's going to squirt some acetylcholine into this prefrontal cortex and infraorbital area of your cerebrum. Okay? And then you do have projections of acetylcholine that go down your spinal cord as well. And the pedunculopontine nucleus is actually important for motor control, and it sends signals down to your flexors and extensors to balance flexion and extension in your body, so there's a dysfunction of that in Parkinson's when people become really stiff and rigid. Part of that stiffness is a dysfunction in the pedunculopontine nucleus, and you're not producing acetylcholine effectively to balance flexors and extensors, so you get too rigid in extension. And then in dopamine, right here, you have an area called the ventral tegmental area in your midbrain. So, you know, here's your midbrain right here, and this is the tectum off the back. Remember, this is the tegmentum, that meaty center, and this is in the front part of that meaty center. It's the ventral tegmental area. It's the ventral part of the tegmentum of your midbrain. That's why it's called the VTA, the ventral tegmental area. That's all you need to know about that. But the ventral tegmental area, it projects axons, again, more to this prefrontal cortex, but also into the basal ganglia. And dopamine is released in those areas in a certain amount. You usually want a certain basal amount of these things being dumped in depending on the status of your nervous system. You know, norepinephrine, that's being dumped in when you're alert and vigilant and you're awake, and you're dumping in a certain amount of norepinephrine. If you need to be even more vigilant, you ramp it up a little bit, or if you don't need to be so vigilant, you ramp it down a little bit. Dopamine, you know, you have to squirt a certain amount of this into your basal ganglia to keep your normal motor output. Every time you send a signal to your motor system, it goes through the basal ganglia first, and you need to have your basal ganglia regulating at a certain level to allow motor output to occur. Not too much, not too little. If you got too much, you got spasms, and you got extra too much movement. You got too little, you don't have enough movement. And so this is all just balancing the nervous system, but that's where most of these neuromodulators, most of them come from nuclei in the brainstem that project their axons to wherever they're going to go squirt this stuff. Okay. So now we're just going to go through each of them pretty briefly, just introduce you to them, what their major role is. So acetylcholine, which is that exception. It could be a neurotransmitter in the peripheral nervous system, neuromodulator in the central nervous system. Its major role is in transmitting information in the peripheral nervous system, including the neuromuscular junction. This is how you talk to your muscles, through acetylcholine, right, being released in the neuromuscular junction. Also, the autonomic nervous system uses acetylcholine when you're activating your autonomic nervous system, and we'll get to that in a few weeks. Okay. It does act as a neuromodulator in the CNS. It goes some of that in the prefrontal cortex, some into the basal ganglia, some to the pedunculopontine nucleus. So it plays a role in motor control. For us, acetylcholine is important for motor control because it does play a role in the basal ganglia circuitry. When we get to the basal ganglia, you'll see, we don't talk about it a lot, but acetylcholine does play a role in normal basal ganglia circuitry. Okay. GABA, it's a G, so it's a neurotransmitter, fast acting. This is the major, I underlined the ones that are really important, it's the major inhibitory neurotransmitter in the CNS. It is an amino acid. When it's released, there's two major type of receptors it'll bind to, a GABA A type of receptor or a GABA B receptor. Okay. GABA A receptors are more predominant in the cerebrum. GABA B receptors a little more predominant in the spinal cord. GABA A, this is again where that mostly, remember, like they're mostly fast acting. So when you bind to a GABA A receptor, which is majority of your GABA receptors, they open chloride channels to cause hyperpolarization. So negative charges come into the cell, hyperpolarize your cell, make it less active. It has less ability to generate action potential. That's fast-acting neurotransmitter role when it binds to GABA A. Things like benzodiazepines, like Valium and barbiturates, those are GABA A, GABA agonists that tend to bind primarily to GABA A receptors. Okay. So they're decreasing neural activity. That's why they chill you out. They're downers. They're neuro inhibitory. Okay, in nature. And so, in the old days, they actually work really pretty well for decreasing tone and spasticity. So they would give people like Valium when they have a lot of spasticity, but then they weren't alert or awake enough to then do things and do therapy or interact and be, a part of life and so forth. So the cognitive and overall, neurodepressive effects outweigh the benefits for spasticity. So then that's when they started looking at other drugs that they could tailor and design to decrease spasticity without causing the CNS depression in the cerebrum. And then that's where GABA B comes in. So you have some GABA B receptors which are more predominant in your spinal cord. And you'll notice that they use a second messenger system. So they're a little more like a neuromodulator here, but we're going to say if GABA for test purposes is a fast-acting neurotransmitter, and I said mostly with all these things. Acetylcholine was kind of an exception. This one little exception of GABA, when it binds to a GABA B receptor in the spinal cord, it uses a G protein-mediated pathway that causes calcium channels to open and inhibit. Okay, and now baclofen is a type of medication that you can take orally, baclofen, or you can take it where they put a little tube right into your spinal cord and squirt baclofen right at the spinal cord level. So when you take it orally, it doesn't have the profound depressive effects of Valium and barbiturates to the cerebrum. It still binds to some GABA A's. So most people who take baclofen, when they first start taking it, you give it to patients for spasticity, they'll notice that they feel pretty fatigued. And some just say it's not worth it. I'd rather have the spasticity than feel this bad or fatigued. A lot of times I try to convince the patients, hang with it for a month or so, and you may notice that those fatigue effects go away, but it helps your spasticity and tone. Because it tends to have it binds more strongly with the GABA B receptors in your spinal cord and less strongly with the GABA A receptors in your brain. So preferentially it causes more decrease in tone than it does decrease in cognition or depressiveness depression of your cerebrum. Does that make sense? If somebody has a lot of spasticity and they got to take such high doses of baclofen that it causes the depressive effects and so forth, then you can take it and squirt it directly onto the spinal cord, and then it doesn't go up. You're not putting it in the bloodstream. You're actually putting it into the dural space there, through a little catheter that's threaded in there, and it squirts right on the level of the spinal cord that you want to decrease the activity in. And then you can micro-titrate it. So you actually can take a patient, and you can they have a little computer, it's embedded in their belly right here, And you can feel it with your patient. If you're treating a patient as a baclofen pump, you just got to be a little careful. I mean, they lay on it, they can sleep on it. You don't want to like totally manipulate it and try to twist it around or anything. Or if you're using a harness system with the patient, you might want to pad that when you put the harness system on, because there's a little catheter coming out that goes into their back and then goes into that intradural space and squirts the back. But you have a little computer you can hold up to it, and you can up or down regulate the amount of dosage, very small doses. It doesn't take a big dose either to do this. It takes a very small dose, because orally a lot of that gets broke down in your stomach and in the bloodstream. Here you're just squirting it right at the spinal cord level. It works for lower body spasticity. You can't use it for upper body spasticity, because if you want to try to downregulate spasticity in the upper body, you'd have to move that catheter. So that when you put it down here, gravity and stuff, it'll only spread so far in your cerebral spinal fluid and bathe that. You got to be a little careful. If you lay down and you have it up too high, that GABA or that baclofen can go up and get in towards to your thoracic spine and cervical spine, and that causes you to not be able to breathe. if you don't want to inhibit your breathing muscles and breathing function and respiratory function. And so they can't do it up in the cervical spine. They can't put it high enough to give you an effect in your upper extremities. So that's where they have to take. If it's an upper extremity, you're stuck with taking oral baclofen. Okay. Glycine, this is a G, so it's a fast-acting only inhibitory. Inhibits postsynaptic membranes primarily in the brain, stem, and spinal cord. So this is less. Glycine is brainstem, spinal cord, not cerebrum. There's still some in the cerebrum, but this is mainly brain. GABA is the one in the cerebrum and spinal cord. Glycine is the one that's mainly brainstem and spinal cord. It probably does similar, opens chloride channels or potassium channels, one of the two, to create some inhibitory, make it more negative in the cell. It's an amino acid. Glutamate. I should have underlined this. This is the major excitatory neurotransmitter of the CNS. It is also an amino acid. It activates a specific protein receptor, just called the NMDA, the N-methyl D-aspartate receptor. Okay, which the NMDA receptor is something you'll read about when we get into neuroplasticity and so forth, and what we call long-term potentiation, where you get this long-term increase in activity of a function of neurons, or adding more NMDA receptors. Your cells can add more NMDA receptors. That's the type of receptor that binds to, that causes fast acting. It's got a protein channel that can open in it and cause, sodium to come into the cell and so forth. If you stimulate, if you have too much glutamate in an area, it can actually cause excitotoxicity and cell death if you overexcite neurons. And this is typically what happens when we have somebody with an injury to the brain, a brain injury. So what happens is, like, let's say you get especially like a traumatic brain injury, where your head gets thrown forward and you shear a lot of neurons. And so when you shear neurons, you just rip apart their axons or their cell bodies or cell membranes. And so those cells mostly die if you've ripped them apart. But then if you're ripping a bunch of neurons apart, they start releasing all their stores of glutamate. They have all this neurotransmitter glutamate that's stored in these vesicles. They all get released at the same time. And so there's a zone or an area around the initial injury that is sensitive to dying off if you start squirting a bunch of glutamate on those cells, and you squirt too much on these cells that are maybe they're in a vulnerable state because they were maybe partially damaged, by that initial insult. They're not, or the blood supply is temporarily not the best to that area. Now you start telling these cells you've got to do a lot of metabolic activity because we're squirting all this glutamate on you. They may not be able to keep up with that response, and then they die off too. Where if you got rid of that glutamate early on, they may, and let them rest, they may be okay. So there's actually medications that they give to people, or when they take somebody and make them hypothermic, they're just kind of decrease the metabolic responses of your entire body, including your brain, to protect those vulnerable neurons that are, being asked to get overexcited by this process immediately after an injury or something like that. So we used to think that as a therapist, if like somebody had a big stroke and they had a big bleed, and some neurons die. They're releasing their glutamate into the area and maybe causing some vulnerability of neurons. We used to think that if we were too aggressive with therapy, and then you go in and you start asking somebody to be aggressive and asking for activation of their cortex and asking them to do motor activity, that you could enhance this effect potentially. They've shown that, immediately within that 24 hours after a stroke, yeah, obviously there's physiologic reasons you're not going to go in and put them on a treadmill or make them do 500 repetitions of a reaching task or sit to stands or whatever motor activity. We really, in practicality, we never do that. There's something we don't have to worry about. Like, we don't have to let somebody rest for 3 weeks and do minimal activity with them to allow the brain to heal. Generally, we don't provide enough activity. We don't provide enough intensity that is needed for the nervous system to repair itself. So, there's they did this with monkeys where they lesion their brain, and then they forced them to do like 10,000 reaching tasks a day immediately after they lesion their brain, and they saw that the lesion got bigger. We never do that in a human. There's no way that we can do 10,000 repetitions of something in a day, forcing our human people to do that after they've had an insult to their brain, immediately after their brain. We're lucky if we get 5 steps in with somebody after a big stroke or something like that. So that's not the type of intensity we're talking about. So we don't know the threshold for that, but it's just kind of interesting. Dopamine. Dopamine also has an effect on motor activity, as it plays a role in basal ganglia activity. We'll get into Parkinson's and all that stuff, and Huntington's disease, and the role dopamine plays in the basal ganglia circuitry. But it also it's very important for motivation, cognition, the pleasure and reward centers. When you activate those dopamine pathways that are coming from your brainstem, those are activated by things like pleasure and certain drugs we'll talk about here, or you'll read about activate dopamine release and so forth. It's a monoamine, so it's an amine. It's a derivative of a amino acid, and the major source of dopamine is from the substantia nigra. This little substantia, and nigra, dark body or dark substance. It's a dark substance. It looks dark. It's stained. It looks like it's got melatonin in it that is a precursor to producing the dopamine, and so it has a dark actually look to it. When you take a cross section through the brainstem, a horizontal section through the midbrain, and look down, you'll see this little dark patch on each side. Which is the substantia nigra, which is in that ventral tegmental area, that front part of the tegmentum of the midbrain. The loss of dopamine producing cells, the cells die off in Parkinson's disease in that ventral tegmental area, and it actually gets lighter, that area. You can't see it on an MRI, but if you post-mortem autopsy, you do a cross-section through that midbrain, you'll notice that their ventral tegmental area, the substantia nigra, is lighter in color than a person who doesn't have Parkinson's disease, because they have less cells that are producing that dopamine that are darkened by the melatonin in those cells. Or I shouldn't say melatonin, melanin. And then serotonin is another neuromodulator. Doesn't start with a G or an A, so that's a neuromodulator. It adjusts general arousal levels, and it tends to suppress some sensory information. So people that have chronic pain tend to have too low of a level of serotonin. When they look at their serotonin levels, they're a little too low. Serotonin is actually really important is produced also during sleep. So people that aren't getting enough sleep, if you have pain and then you don't sleep, you don't produce enough serotonin to help inhibit your pain, and then you're now not sleeping even more, and so it's this vicious cycle that you can get into with chronic pain and so forth. It also plays a role in the descending pain control system. So, but it also associated with depression and suicidal behavior and mood. Serotonin is very important to us as physical therapists, from not only its pain modulatory importance, but also its role in depression and motivation in our patients to even be able to do the exercises you want them to do and so forth for their chronic pain. So you have to kind of understand the big picture, that you're dealing with somebody, if they've got low serotonin levels, who's going to have heightened responses to pain, but also be less motivated. not because they choose to be less motivated. It's not a willpower thing. It just might be their serotonin levels are low and they're not sleeping good. So asking about their sleep and finding out, I spend a lot of times with patients who are in a lot of pain, like, we got to find a way to get you to sleep. If you're not sleeping well, nothing else is getting better at this point. You're just going to be depressed. You're going to be tired. You're going to be lack of motivation. So we need to find a way to get you to sleep better. And it's also a monoamine. Norepinephrine, remember, that projects to wide areas of your cerebrum, plays a vital role in active surveillance of your surroundings. When you're alert and awake and actively interacting with your environment, your norepinephrine's are high. Okay, the highest levels are associated with vigilance, and the lowest levels occur during sleep. When you're asleep, you don't produce much norepinephrine. You don't need to. You don't need to be. You're asleep. You don't need to be vigilant. Norepinephrine binds to alpha and beta receptors. Okay, and it's essential for producing that fight or flight reaction. Okay, it plays a role in the sympathetic nervous system. So in the periphery, in the central nervous system, it makes us alert and vigilant. In the peripheral nervous system, it does all that. It increases heart rate, breathing rate, causes some vasoconstriction depending on if it's in the periphery versus muscular areas where these. And those little guys will learn about beta blockers and all that stuff, and alpha blockers. So very important to understand the role of norepinephrine in the autonomic nervous system as it affects physiology, cardiac, vascular physiology, and respiratory physiology, via the sympathetic connections here. Substance P, also a neuromodulator. It's mainly within the spinal cord. Okay, substance P but it does act as a neurotransmitter. Here's the little exception here in the nociceptive pathway. But at other sites, substance P acts as a neuromodulator, but we're going to assume it's mostly a neuromodulator. Okay, usually producing long duration excitation of postsynaptic membranes. So it enhances the excitation that a postsynaptic membrane is more likely then to respond to the next signal. So substance P enhances like pain transmission and pain signals and so forth because of that G protein mediated neuromodulatory excitation of postsynaptic membranes. And it's a peptide. Endorphins. Endorphins are found in areas with opiate receptors, including the substantia gelatinosa, hypothalamus, periventricular gray. You don't need to know these now. We're going to get into these and you'll figure out where some of these are. And the periaqueductal gray. Those are areas within the substantia gelatosa and hypothalamus in the cerebrum. These periventricular gray matter and periaqueductal, actually periventricular gray is also in the cerebrum, but periaqueductal gray is in the brainstem. But so there's various areas where there's opiate receptor cells that have predominance or have a greater number of these opiate receptors. Their primary action, endorphins, will bind to those opiate receptors and inhibit pain, primarily slow pain pathways. So after you've had pain for a while, your body will produce natural endorphins and to bind to these opiate receptors and help down-regulate your pain, hopefully. But not all of us have good endorphin systems, and certain things like physical exercise and so forth and sleep can make sure you have enough endorphins so that if you have long-standing pain, your body can do a reasonable job of inhibiting pain by binding to those opiate receptors to down-regulate and modulate your pain to an appropriate level. However, if you don't do things like physical activity, don't get sleep, you're not likely to produce the right levels of endorphins to help your system kind of fix itself or modulate itself. And it's also a peptide. This is just from your book showing you the kind of most common neurotransmitters, and then they bind typically to, most of them bind to more than one type of receptor. And those receptors can cause slightly different actions and can be in different regions of your system, and your different regions of your nervous system, or on different, in your cells in your lungs or your bronchioles, or on cells in your different muscle cells or glands. So depending on the neurotransmitter, the type of receptor, and the location of that receptor, all that will influence what the activity that or response is to that, binding of that. Okay? Just some clinical considerations. Some of these we kind of already mentioned, that, you know, neurotransmitter agonists and antagonists. So most drugs that affect the nervous system are either mimicking a neurotransmitter and acting as an agonist to that for that neurotransmitter, or they're blocking that neurotransmitter in some way and acting as an antagonist to those effects. Okay. Examples: botulinum toxin, Botox. When you inject Botox into a muscle, you block the release of acetylcholine from being released in the neuromuscular junction, so it causes the muscle to be weak. Which, if you're trying to, you know, make somebody look less wrinkly, you block them in their forehead, so if their forehead doesn't crinkle up, you know. If you have somebody who has a lot of spasticity or tone in their gastroc muscle, which we saw yesterday, this gentleman was on the treadmill yesterday, and he'd get some, you know, clonus, we call, where you get this, you know, quick stretch reflex that is, you know, keeps going and keeps self-stimulating, and it's called clonus spasticity. So we might, you know, we've talked about with this guy, maybe we should consider getting you Botox into your gastroc muscle if it becomes a barrier to our progression. Like, the faster we work on walking with him and those kind of things, the faster we're getting a quick stretch of the ankle muscle. But right now, you know, sometimes just walking on it and we've got him in a brace, that will get your system to kind of modulate and dampen the quick stretch, and you get used to it. So if we don't need to get a Botox injection, because what happens when you inject a muscle with Botox, it weakens it. But he still needs his gastroc to push off, and we want his muscle to be active. So if, you know, there's just always those trade-offs. And I've had patients, or baclofen, you know, is a different. Baclofen affects the spinal cord to down-regulate muscles below a certain level. So when you put baclofen into like a tube into the back, and it's getting in there, that, you know, L1 level, it's going to down-regulate it's going to weaken all the muscles below L1. It's going to make their spasticity better, but I've had patients who said, oh, this tone is just bothering me, my spasticity, my spasms, I want to get rid of it. You give them a baclofen pump, and they do a trial with this to try to hopefully not have this effect. They put it in, and no matter what the dosage they titrate, to get rid of the spasticity, now their muscles are so weak they can't do a sit-to-stand transfer. They can't even use their legs for, you know, just getting and locking their knees out to do a transfer. And then they're like, crap, you know, I need that. I need that tone to do function. And so be careful what you ask for sometimes. So, but that's, you know, baclofen is that binds the GABA B receptors. Beta blockers like propranolol blocks beta-1 receptors of norepinephrine, which then helps to decrease blood pressure and heart rate and those kind of things. Sinemet is a drug given to Parkinson's patients. It's made up of what's called L-DOPA, which is able to get through the blood-brain barrier, and once it's in there, then L-DOPA is then converted to dopamine. So things like selective serotonin reuptake inhibitors, SSRIs, those are common, you know, antidepressant medications. They prolong the life of serotonin in the synaptic cleft. So even if you have less serotonin being produced, if you keep it in there longer, there's more likely you're going to get more binding and get more of the receptors filled with it, and it's going to stay in there, be a little longer acting. So some of your patients, if they're depressed or if they have chronic pain, will be on SSRIs to try to keep whatever serotonin they have in their synaptic clefts a little longer to increase the activity. Then monoamine oxidase inhibitors, they prevent breakdown of several different neuromodulators. They produce, monoamine oxidase is an enzyme that breaks down the neurotransmitter in the synaptic cleft. But if you block it, it's an inhibitor. If you inhibit the monoamine oxidase, then these serotonin, dopamine, and norepinephrine will stay in the synaptic cleft longer before they get broken down or before they diffuse away. So you're just increasing, but this stuff is such, like, you know, for anybody that's been through that challenge of trying to figure out what medications for you work to get the right balance between serotonin, dopamine, norepinephrine, and problem is everybody's body responds differently to those medications. And actually, you can be on them for a while, and then your body will change. And then you have to go back and try to tweak the medications again to maintain the effectiveness of that, because your body habituates to things, and your body changes, and so many things influence how your receptor activity works and so forth. Hormones, other things, and stress, and those kind of things. So it's really kind of now they're getting genetics too, and so there's even things where you can go get genetic testing done to see if you're more likely to respond to a certain one of these or combination of these medications than others. It's not quite the best yet, but they're getting closer to helping kind of provide people, instead of just trying. And most of these drugs, because they're G protein mediated, they're longer lasting. They take at least 2 to 4 weeks before you can tell if they work. And then if you decide, well, crap, after a month or two, that's not working, now you have to wean yourself off of that drug, because you can't just go cold turkey on most of these, because you've got your nervous system to a new changed state. And if you just pull yourself off, your system will get a little out of whack. So now you wean yourself off for another 2 to 4 weeks. Then you try the next one for another 2 to 4 weeks. Wean yourself, so it could take you a year and a half before you might find something that might work for you. And by then you forgot what you normally even feels like for a lot of people. So that's always a challenge with these. Diseases involving synaptic transmission and neurotransmitters. Parkinson's, we mentioned, is a lack of dopamine from the substantia nigra. There's a very rare, but some people with small cell carcinoma of the lung, it produces an immune response which then creates antibodies to calcium channels. And so they destroy their immune system, an autoimmune response that destroys calcium channels, so then they get weakness and motor weakness because of this, because you can't get the muscles to contract because you block the calcium channels that are important for at the neuromuscular pathway. Myasthenia gravis is where another kind of immune response, autoimmune response, where you produce antibodies to the nicotinic acetylcholine receptors on muscle cells. Those are the fast-acting acetylcholine receptors that help you contract your muscles. And so myasthenia gravis also causes weakness of muscles, especially muscles that you have to fire all the time, like eye muscles, postural control muscles that are on all the time, because you're having to secrete acetylcholine. They're the ones you'll see the weakness in first, typically, as they're muscles that are constantly being asked to fire. And then depression, we've mentioned. Depression can involve abnormalities in any one of these major neuromodulators that have vast networks into your cerebrum, and the balance between those different neuromodulators can all cause changes in mood and affect. Well, so do you guys know what you're doing in farm yet today?